Good afternoon, everybody. My name is Zach Stanley, and I'm an Executive Vice President here at MassBio and today's forum moderator. In addition, just to give a quick introduction of myself, in addition to my leadership position here at MassBio, I also lead our public affairs team, which includes our government affairs, communications and marketing, patient advocacy, equity, diversity and inclusion, and workforce development initiatives. I'm really excited to moderate today's forum. Thank you all for attending, and I think it's going to be a great discussion. Today is World Obesity Day. We are having this discussion today on obesity for a reason. It's a really interesting topic, and I think overall it doesn't get much attention, especially from a medical, scientific, or therapeutic perspective, but it certainly has major implications for public health. Obesity is top of mind for a lot of people right now because it is listed as a comorbidity as it relates to COVID-19 vaccine prioritization. So it is getting a lot more attention than it has in the past. And people are asking themselves, what does obesity mean? Do I qualify, and how does that impact my ability to get a vaccine? I think today's discussion may enlighten people a lot on the topic of obesity. Personally, as a tall, skinny guy, I haven't really given much thought to obesity in my life, but as I've talked with our panelists today, I've really learned a lot, and I've come away with a completely new understanding of what it means to be obese or to have obesity. Before we start, I'd like to give a big thank you to today's forum sponsor, Novo Nordisk, and especially thank you to Kate Berry, our local government affairs representative from Novo, who's been especially helpful today in getting this panel together and educating us on this important topic. The structure of today's forum is a little different. Today we're going to start with a quick video that I think is going to help set the tone in a really nice way for today's discussion. Following that, we'll hear presentations from two local experts in the field of obesity, and after their presentation, we will have an open Q&A. So at any time during today's event, please enter questions in the chat box on YouTube. We will get to them, as many as we can, during the Q&A session at the end of today's session. And with that, I would like to introduce this awesome video.
Hey, fatty, stop eating.
I don't want to judge, but if you realize that you're becoming bigger and bigger, maybe you need to do something about it.
It's a mindset thing. You just have the right mindset and you can accomplish anything.
Do exercise. Zumba, for example, like me.
I know, it's not politically correct, but...
Take responsibility.
I mean, they're not ugly, but...
Everyone has 20 minutes to do something.
Don't eat a burger every day, or, I don't know.
Just stop eating. It's that simple.
Okay, Bryce, just wanted to read from the teleprompter.
Right here?
Yep.
All right. I am here today to talk about something we have neglected for far too long. Why the SIBO?
Why the SIBO causes 2.8 million deaths every year.
It is heavily affected by our genes, the hormones, and the environment we live in.
And there is not a single country in the world that has reduced the number of people suffering from SIBO for over 30 years.
When you suffer from this disease, it impairs your body's normal functioning, and it is very hard to fix yourself.
Studies show that 40% of people living with SIBO experience judgment and humiliation,
Making them feel ashamed and afraid to ask for help.
Today, about 650 million adults live with it.
living with SIBO is a health issue, not a character flaw.
It is time to rethink what we know about obesity. Y'all could... Oh man, we talking about obesity?
Oh, it was back to front.
This is a joke.
I feel really bad. I technically body shamed him, kinda.
It's funny because we just judge, like without even thinking about it.
It's more than just a diet and exercise. It's a really serious disease. I'm sorry, guys.
How does that make you feel?
I feel bad, like I'm part of the problem. They're sick, they're sick, they're suffering, and I'm judging them and saying, oh, stop being lazy. Like even my own brother. But I ain't know. Like, I really didn't know, man. Like,
Well, I think it's maybe important to rethink how we can help people.
Isn't that a great video? I watched it for the first time this morning and I was just blown away. I can't remember a video that's changed my mind on a topic so quickly with such a great attitude and levity about it. With that, I want to introduce John McDonald. John is a corporate vice president and head of global R&D at Novo Nordisk. He is also leading the Novo's Innovation Hub here in Cambridge. John's going to kick off today's program and provide introductions of our two panelists. John?
Thanks so much. I'd like to thank first the Mass Bio and the speakers for helping to put a spotlight on the obesity epidemic and to briefly discuss what we're doing here with our Innovation Hub in Cambridge. As was said, I'm John McDonald. I'm the global head of R&D business development at Novo Nordisk, and I'm also the site head for our Cambridge office. This office opened in Cambridge in approximately 2018. It opened with 3 people. And when we finally returned to our office after the COVID allows us to do so, we will have moved up to 20 people and growing. So this is a really important place for Novo Nordisk because it holds the greatest density of innovation probably in the world. Our simple purpose in this office is really to understand the innovation ecosystem in Massachusetts and beyond, and then access that innovation system. Here in the Cambridge office, we have an early innovation unit that literally seeds innovation at universities, venture capitalists, and very early stage biotech companies. So really trying to find out, is there biology or is this a platform? So that's one area. So we start very early. We have a search and evaluation and transaction team that will go out and work on platform deals and preclinical deals to bring those programs into Novo Nordisk. And then we have an alliance management group that will manage that alliance over time. So seeding early innovation, finding deals to do, and then managing those deals. That's really what we do out of this office. And just to give you a flavor of what we've done, in plus or minus the last 15 months or so, we've signed at least 4 deals that are based in the Cambridge or the Massachusetts area with universities and biotechs. And if you just look at 2 deals, one with Dicerna and one with Corvidia, Novo Nordisk paid $950 million upfront, $225 to Dicerna and $725 with Corvidia. So it's not just a small amount of contribution or commitment we're making here, we're making a very large commitment. And then when you look at Novo Nordisk a little bit more generally, we look at we work in a whole bunch of different areas, but there are a few areas that are really, really hard areas to work in. And we invest in those areas, and very, very few companies do that investment. One of those is cardiovascular, one of those is diabetes, and the last area is obesity. And as you've heard from the film or the video, and what you're about to hear a little bit more of, this is a really, really trying disease. And we look forward to being one of the greatest companies to tackle that disease over the coming decades. So with that, I'll introduce our panelists. First is Melinda J. Watman. Melinda is chair of the Massachusetts Coalition for Action on Obesity and sits on the board of the Obesity Action Coalition. Second, we have Dr. Angela Fitch, who is the Associate Director of the Mass General Weight Center in Boston. The Weight Center is a multidisciplinary center for the care of patients of all ages with obesity, including dietitians, psychologists, obesity medicine physicians, and metabolic surgeons. She is Vice President of the Obesity Medicine Association and faculty at Harvard Medical School. She is board certified in internal medicine, pediatrics, and obesity medicine. And with that, I will turn it over to Melinda and Angela. Thank you.
Melinda, you're on mute.
Hi. So we're covering the obesity epidemic and the lack of access to care and treatment. But first, I'm going to talk a little bit about what it means to have obesity. And so, next slide. Before I do that, and this is somewhat already been acknowledged, but Novo Nordisk has been an incredible supporter of both the Mass Coalition for Action on Obesity, but also just a pioneer in the treatment of obesity. And we just really want to acknowledge that because it's so important. Next slide. All right, so I'd like you to close your eyes. And I would like you to imagine what this person in your mind looks like. Active, generous, successful, commanding, leader in the community, well integrated into his family, her family, her family, incredibly accomplished and well thought of. So imagine what that person looks like, his, her. And next slide. And generally speaking, this is what people envision. So plus or minus, a little older, a little younger, dressed a little bit differently, but typically this is what this person that you've imagined looks like. There'll be a few of you that have different images, but we find that this is the standard. Next slide. So this person you probably did not imagine. And this person I have a personal relationship with. This is me. I have obesity. Next slide. I still have obesity. Obesity is a chronic disease that I have and will always have. And regardless if I look like the previous picture or this one, I am still accomplished, powerful, successful, et cetera, et cetera. And so that image that people walk around with of slovenly, lazy, no willpower, et cetera, we have to break that. We have to start thinking about people with obesity are people, and they live a life, and they live a successful life for the most part. So I think of myself as in remission. And I'm in my mind a heartbeat away from 225 pounds. So it's a very complex disease, and it hits us in various ways. So I just want you to understand that that picture before and this picture now, same person, same thing. So next slide. So let's get into what it means to have obesity and what it means to have weight bias thrown at you all the time. Next. And so this is really to give you a little bit of information about what's happening with obesity in Massachusetts. And you can see that basically the cost in Massachusetts of obesity is enormous. I think it's just shattering when you think about what that money could go to just in treating obesity, so that we've got less investment in having to treat all of the comorbidities, and we've got way more ability to spend that money in other positive ways on obesity and other areas. So don't lose sight of obesity costs us a lot of money, and a lot of it can be treated and eliminated. Next slide. So what is weight bias? And next build. Weight bias is, as you can see, and as I said earlier, the negative attitudes towards those with obesity. It can come in all forms. It is subtle and overt. And I think one of the most damaging things about it is internalized weight bias. So if you imagine this, you're a person with obesity and you have coming at you all kinds of assaults, verbal, relationship, cyber, physical, bullying. You could be any age and experience these things. And unfortunately, if you hear them enough, you take them in and you become your own worst enemy. You've internalized all of those things that exist outside and become part of you inside. And so that tape begins. I'm no good, I can't be successful, I'll never lose weight, etc. I mean, it's just endless. I remember having this tape 24 hours a day going, and there was always something negative about it. My first experience with bullying, just to give you an idea, I was in kindergarten. The first day of kindergarten, it took all of about 32 seconds. So my maiden name was Katzman. It took all of about 32 seconds for the mean kids to rename me Melinda Fatzman. And this is what I had through elementary school, if you can imagine. But the worst part, in retrospect, the worst part was not a teacher, not an administrator, not a principal. Nobody ever said to those kids, stop that. That's not nice. You shouldn't be doing that. They were so hardwired into thinking, oh, no problem. You can make fun of the fat kid. That they just simply were given permission. So that was my first bullying. And I took it in. And as a result, I believed I was the worst at sports. I was the last one picked for everything, and on and on and on. I was smart, so I never failed at school. But externally and internally, there were huge failures emotionally. Next slide. As something that you may do, and maybe some of you have, if you Google Harvard implicit bias weight, you will come up with a link that looks like this. That is a weight bias, implicit bias, obviously, study. It is fascinating. Even I, who in the biz, so to speak, was fascinated with my results. It's definitely something worth doing, and it gives you a real insight into how you sort of fit on the spectrum of bias. Okay, next slide. So when you look at weight bias, and when you look at how do I feel about someone with obesity? How do I act towards someone with obesity? And what do I do if I'm with people who are making really negative, nasty comments about someone with obesity? These are things that are really important to explore. And I think that, you know, if you come up with things that are not necessarily, I'm going to use the word nice, because I think we all have thoughts that are not so nice. Those in a way are good, because you can work on them. You can think, wait, why do I feel that way? How can I change that? How can I at least change the way I think about this? Which is very hard to do. We'll talk about it in a little bit. But I want to talk a little bit about people who make disparaging comments. So I'm in an interesting position. I was 225 pounds, now I'm not. So I'm in a group, nobody knows my story. And one of the people in the group makes a really nasty comment of someone walking by who has obesity. I am now one of the thin people who, good, clean fun, ha ha ha. And the question is, what do I do? And the same with you, what do you do? Because that's the important piece. I look at it as a teaching moment. It's something that you can help other people see as not acceptable. And it's a little dicey. I mean, how do you do that? So I have the ability to say, oh, you don't know my story, and talk a little bit about my story and sort of make it casual, but people are like, oh. And because of it, reframe a little bit. Now, do they change their behavior? I have no idea. But in that moment, you know, they have this sort of look on their face. They went, maybe I shouldn't have said that. Maybe I should have, you know, kept my mouth shut. Or, you know, you could say something like, I'm sorry, what did you say? But you have to think about what it is that would motivate you to make a comment. And I encourage you, I really encourage you to do that. Because even if one person walks away thinking, maybe I shouldn't do that, you've been a huge success. You have made a difference. Next. So we'll move on to behavior. Next piece, speaking versus doing. So I call it the evil twin syndrome. Like the slide before, I think that we all have a little bit of an evil twin. And it's sort of like our back voice. It's not so nice, that sometimes you want to say whatever you want to say. And it's because, to a large part, we've been hardwired. It's just in the culture. And changing someone's mind, if you think about it, like I hate celery. Everybody can say to me, oh no, celery's great, you should try celery, really, you're gonna love it. Well, there's no way. You're not changing my mind, I hate celery, it's not gonna happen. Same thing. In your mind, you're thinking fat people, blah, 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 whatever you're thinking. Truth is, I don't expect to change your mind immediately, but I do think you can change how you act towards someone with obesity. And I also believe that behavior repetition can lead to a change in your mind. But I'm not after the evil twin. I'm after how you act initially. And then we'll see what happens. If you change behavior, great. And I do believe people do. Repetition is a beautiful thing. So I do believe that you can. Next. Yeah. So this is sort of the epitome of how the evil twin acts out. So there's someone who's getting on a plane. In her mind, she was having her nasty thoughts, and she looked at the flight attendant and says, why don't you sit in between those two big pigs? Next build. And the difference is the person who said, after thinking the same thing as the other person thought, excuse me, that's my seat in the middle. So you can see how behavior makes a difference. That other person thought about what that person said exactly what was good, but had the other thought in their mind. So you can see how just that little shift. Next slide. Language also matters. How you speak of someone with obesity makes a huge difference. So first of all, respecting people in general, I think all of us know. And that includes people with obesity. My husband says, oh, people look at it as just clean fun. It's the last bastion of public humiliation that exists. You could never say the things that you say about people with obesity about any other group. It's unacceptable. And it should be with obesity. So one of the things that we talk about is people first language. What it means is using the word obese. I have an obese patient. My friend is obese. That defines them. It's an adjective. It defines who they are. It negates everything else they are. First and foremost, they're obese. As opposed to using the word obesity, because in fact, obesity is a disease. And so my patient has obesity. I have a friend with obesity. You would never, just to give you an example, you would never say about someone who has cancer, I have a cancerous patient, I have a cancerous friend. That's an adjective that defines them. We would never say that. So similarly, using obesity is the same. And I think that we all have the opportunity for teaching moments. When you hear someone say, she's obese, he's obese, it is an opportunity to say, oh, you know what? Obesity is a disease. So we really say she has obesity. And it works, I must say my husband was a tough nut to crack, but he now looks at me. If he ever says the word obese, he just looks at me and goes, has obesity. So it's possible. You can make it happen. So anyway, I do think that teaching moments are important. Next slide. This I have found amazing every time I look at it. the bias, those horrible things people say, first and foremost, friends and family. When you think about that, how much time people spend with their friends and family, and how hurtful that has to be. I had a friend, we were in our 30s, who once said to me, well, why don't you just exercise more and eat less? I literally smacked my forehead and said, why didn't I think of that? People say the most amazing things. And so, when I was young and older, we would have, large groups of people for holidays, celebrations, for dinner, and there'd be like 12 or 15 people around the table. And dessert would come. And my mother would look at me and say, do you want a taste? Now, I die inside every time that happened. When I went shopping for clothes, it was a nightmare. All I could think about was, oh, please God, let something fit, so that I didn't have to go through this whole thing about finding clothes that fit. So friends and family, they don't mean they don't mean to be mean. It's just, it comes out. And in some ways, they feel like they're helping, but they're not. And then you can look down the list and see popular culture, obviously, we're, the hardwired part of us that just says nasty stuff to people with obesity because they can, is the next leader of the pack. And then we get to healthcare, which is very interesting. Next slide. We hope this is a healthcare slide. Yes, it is. And we'll go to the next slide too. Weight bias in healthcare is pervasive. There is, next slide, there is incredibly well-documented pervasive health bias across providers. Doesn't matter who you are, what you are. There was a study done on nurses, and I'm embarrassed to say this because I am a nurse, that said that nurses would rather not take care of people with obesity. They would rather not touch them, and they would rather not have to interact at all. Now, if you think about that, that is a horrific outcome from a study. I mean, I have obesity and my nurse doesn't want to touch me, doesn't really want to care for me. Nurses are responsible for good care, for delivering everything I need. And in fact, not going to happen. Not in the way they would take care of a thin person. So next slide. So what happens is, as you can imagine, the quality of care goes down. Patients are totally not taken seriously, less time spent with them, and a reluctance to perform certain screenings. Obviously, the patient ends up stigmatized and then stops going because they don't want to be put in that position. I had a PCP, I lost 30 pounds. I went in feeling pretty good, and my PCP looked at me and said, "Is that all?" I was devastated. I left the office. And what was the first thing I did? I ate and ate and ate until I gained 30 pounds and then some. So clinicians have an incredible power that they can use well or they can abuse. And so many patients have been abused by just the way they're talked to. There's a study that shows that women who avoid care because they're stigmatized have a higher rate of advanced breast cancer and cervical cancer that could have been treated much earlier on had they gone to see somebody. So very important. Healthcare really has to make a shift in how they take care of patients. Next slide. Yes, so this is my little humor of this person comes impaled, and you should lose weight, it'll take care of everything. And that's kind of how clinicians act. Nothing is serious except their weight. Next slide. This is what I talked about the 30 pounds. And the other thing I can say about that is many times when I go in to see a clinician, now I was big, I'm 5'1". The clinician would never even bring up my weight. That's the other thing, total avoidance. Never mention a word. And let's face it, it's hard to miss. So there's that piece too. And again, ignoring the care that they should be giving. Next slide. So, and you can do the build. This talks just about, you could just do it all across. This talks about what happens when, particularly where COVID-19 is involved, avoidance of care, blame and shame, worsening of symptoms, and then ultimately in the hospital leading to much worse outcomes, ultimately higher rate of death. So we really have to help our patients understand that we are going to take care of them well. We're not going to stigmatize them. Next slide. Much what I said, so we can go on. So this is important. What can you do? How can you help? Obviously, support, and you are, the efforts of organizations. And this is a perfect example of doing that, which is wonderful. The other big piece is, and Angela's going to talk about this a little bit, the other big piece is legislation. There has been a bill in the Massachusetts legislature for years that hasn't been passed. It's a tiny little piece of adding height and weight to the anti-discrimination bill that already exists, law that already exists. We have not been able to get it passed. So things like that, again, they matter. So supporting legislation on a local level and on a federal level is key. And then the last bullet, conscious of weight bias and conscientious about stopping weight bias. I'm leaving you with those two things. Those are your jobs. Next slide. And I'm leaving you with this, and then I'm going to leave into Angela because this is her. She just came as brilliant. She just came out with it. It's not your character. Remember, it's not our character. It's not my character. It's my chemistry. I couldn't succeed without the aid that I got. And so now I will pass it over to Angela.
Thank you so much, Melinda. That was wonderful. And as they transition the slide deck here, I will just say that I'm going to build on what others have said, or what Melinda has said and what John had said earlier, is that, one of the biggest access to care issues is the fact that some of these things that Melinda described, right? Some of this internalized bias, and you can go on to the next slide. Some of this internalized bias, some of this access in terms of patients not even thinking disease is treatable, right? Primary care physicians, other physicians not even thinking the disease is treatable, which is one of the reasons why we have Obesity Care Week. This is Obesity Care Week. It's a whole week, and today is a World Obesity Day. And the theme is everybody needs everybody. So we all need to be in this together, and that's the biggest thing I hope you'll take away from today. Because 30% of annual healthcare costs, people with obesity spent treating obesity-related conditions. So $480 billion, 230 diseases and disorders that are linked to obesity that we could help change if we could just help the obesity in the first place, right? And if we think about too, nearly 50% of older adults are expected to have obesity by the year 2030. And this was numbers prior to COVID. So, how that's going to happen, how that's going to play out is going to be the next thing to discuss. Next slide. And again, the biggest thing I want to highlight today is at the top of this slide, which is obesity is a chronic, treatable, multifactorial disease. So obesity is something that is treatable, right? It's a disease. We first have to acknowledge that. But we more importantly have to acknowledge that there is treatment and there is help. And that's what we have to get across. And that's the idea of today. Next slide. The state of obesity is shown here in this graph that should be moving as we speak, showing you the increasing redness of the states, if you will. And you can see the lower states, especially in the South, which are greater than 35%, and this data stopped in 2019. But you can see that across the country, this is not an issue of just one area, this is an issue of the world, which is why we have World Obesity Day. On the next slide, you'll see that we also have an issue in our pediatric population, unfortunately. As John mentioned, I do both adult and pediatric obesity. And in our ages 10 to 17, you can see in most of the states that are in that blue color, at least 10 to 15% of our kids in this teens in this age group already have obesity. The studies would show that these teens go on to have obesity as an adult. You do not outgrow your obesity when you unfortunately have it by the time you're in your teens. So it's really going to be an ongoing problem for these patients. Next slide. As Melinda mentioned, obesity is costly. 14% of total healthcare expenditure in the United States, and we're at the top. Not a place we want to be at the top. 2/3 of diabetes cost is attributable to obesity. 1/4 of cardiovascular spending. So not only do we get rid of some of the other, first of all, people get healthier when they treat obesity, they feel better, they live 7 years longer on average, which has been shown in the bariatric surgery studies, but 9% of all cancer care costs are gone because obesity is gone, right? There's a 30% increase in cancer risk related to obesity. And so again, there's a lot of diseases that would get better if we were treating obesity seriously and we had better access to care. Next slide. So this is the problem though, right? Weight loss is abnormal. To be losing weight is not what the human body is engineered to do. When the body starts to lose weight, if you look on the left-hand side of the screen, you'll have when people decrease their calories or try to eat differently and they increase their activity and weight loss happens, unfortunately on the other side, the human body slows our metabolism. So you've now lost weight and you're doing a good job, but your body slows your metabolism down and prevents you from losing more weight, right? So not a good thing. It also increases hunger hormones and it decreases hormones that make us feel full. Our body is regulated. It's why we tell people, if you're hungry, wait 20 minutes until you get your second helping, because it takes 20 minutes for these hunger hormones to work, for you to feel full, which is also why a lot of times you might have Thanksgiving meal, for example, and you afterwards, you're like, 20 minutes later when you're, watching the big football game on TV, you're like, oh, why did I have those last few bites, right? Because that's caught up with you, right? But unfortunately, when we lose weight, these things change and they don't give us an advantage, right? We now have a metabolic disadvantage, and that's what we have to work to change. Next slide. So all of these set point factors play a role. This is why obesity is so complicated. It's not just about eat less and exercise more. It's about processed diets, irregular eating, how active we are, not necessarily how active we are from a physical activity, but just how much we sit. Sitting isn't good for us, decreases our metabolism. Inadequate sleep lowers our metabolism. Stress, weight increasing medications that we're on, and life changes that we can't really do anything about. But at the base of all this is our genetics, right? Our genetics is what really loads the system, that where the environment around it. And then the next slide, as this builds here, you'll see that as all these things happen, that set point gets turned up and our weight at the higher levels becomes more and more sort of where we're set at and harder to get down. Next slide. So what works for obesity treatment? I like to use this acronym that I made up called SAME, because it helps me remind me of what works for obesity treatment in general in a big scheme, right? People need structure to their lives. We have got a lot of unstructure in our life, especially today, and we have to have a structure in order to be successful with a lot of things in life. We have to have accountability. We have to have a metabolic alteration that actually promotes fat loss. We have to have this metabolic advantage, not metabolic disadvantage that we're unfortunately gifted with by Mother Nature. So having surgery, medications, different dietary patterns, different focus on our sleep and stress, this helps to give us a metabolic advantage. And then we need to be able to work on controlling our environment, because the environment out there today is producing 80% of people in the country having an abnormal weight by the year 2030. So if the environment is producing 80% of people to have excess fat storage, then there's something wrong with the environment, right? I mean, it's not giving us what we want. So we have to change that and make that different if we want to make it different. Next. So in 2012, the US Preventative Task Force recommended as a grade B recommendation. In the next slide here, you'll see that this intensive multi-component behavioral interventions, right? As the slide builds and we hit the next slide, you'll see that at the bottom there, this is what's recommended as a grade B recommendation: 12 to 26 sessions, a dietitian, a physical therapist, an occupational therapist, a behaviorist. The grade B recommendations are supposed to be covered with no cost as a preventative service like a colonoscopy or a mammogram, right? Because they're so helpful in making a difference in people's lives. Yet we don't have a healthcare system yet, even since 2012, in 10 years, that's been able to figure out how to deliver this in a way in which it gets reimbursed successfully. And this is our biggest challenge in access to care, I think, is to figure out how can we reimburse these services and make them available to patients so they can get that high intensity treatment and accountability they need. Next slide. I have this obesity treatment pyramid too, because the treatment shouldn't just be one thing. It shouldn't just be eat less, exercise more, right? That's what we're trying to get away from. It needs to be this multi-component therapy that builds on each other, that at the base of it is lifestyle modification. But then we have things like prescriptive nutritional interventions that may focus on different timing of eating or different macronutrients that might benefit one person over another. We have pharmacotherapy. We have endoscopy procedures now. And then at the top of the pyramid, we have surgery. And one of the issues is that we don't see this as a building thing. Patients see this, like I said, as their character, that they've failed in their lifestyle modification, when really lifestyle modification scientifically has been shown to produce a 2 to 5% weight loss. That's not a lot of weight loss. And so sometimes, people want more than that, or people need more than that to resolve their diabetes. To put diabetes into remission, you need a greater than 20% weight loss, and you need to maintain that weight loss, that tug of war, for longer than 10 years. Next slide. And here's where I'd like to highlight that, right? So if you look at the slide on the left-hand side, this is the percent weight loss with each intervention. And so if you look at, in the next slide, this will circle an area here on the table. Next slide. So if you look at 15% weight loss, so let's say we want to get 15% weight loss because we want our non-alcoholic fatty liver disease to go into remission. We want our diabetes to go into remission. With intensive behavioral therapy, which is that grade B recommendation, 12% of people are able to do that, able to accomplish that. But if you layer on top of that, like the pyramid, right, in the next column where metabolic surgery is, you can see that 72% of people, greater than 72% of people, are able to do that with surgery. That's 7 times the amount of people, 7 times the chance, right? With doing the same factors, because people who have surgery still have to do the column number 1, right? Column number 1 is there no matter what. You have to do this behavioral therapy no matter what. And then if we look across the table from left to right are our medications. So semaglutide 2.4 milligrams is a new medication that that'll be coming out hopefully this summer that you may have read about in the New York Times, which is producing now 56% of people able to get into that 15% weight loss category. So again, 5 times the amount of power to get people into that category and help them stay there. 5 times the amount of power on that tug of war, right? 5 more people over there to tug on the other side, right? And with liraglutide, 3 milligrams, what we have today, we have 36%. So even the treatment we've had for the past 5 years on the market, we have 3 times the amount of people able to get into that category. Next slide. And this just highlights the access to care issue, right? Is that at the top in insurance denials, that's one of our biggest issues today, is these medications are only covered by less than 30% of employers in the country. This is a add-on benefit. It's not a standard benefit in most insurance plans. So employers have to choose to add obesity treatment coverage. The Treat and Reduce Obesity Act is before Congress right now. It's been before Congress for quite some time. And we encourage everybody to support legislation that would help to pass that act, because that would allow CMS coverage of this intensive behavioral therapy, of these medications that have 5 times the ability to get patients into that category that they need to be in. Next slide. And these are the ways you can improve access, because I want to have time for plenty of questions. But the biggest thing is to, again, encourage insurances to cover anti-obesity medications and lifestyle support programs. So we need the whole package, right? And surgery's mostly covered now. That we've made a lot of progress in getting surgery covered, which is a great thing. But we need to fill out the rest of the pyramid and get the rest of the pyramid covered as a standard benefit in health plans, right? Especially on our public health plans, because unfortunately, people who are of lower socioeconomic status also tend to struggle more in the obesity epidemic. And so again, those people on public health plans need just as much attention to this as anybody. Encourage people to seek out obesity treatment. Again, it's your chemistry, not your character. You need help with this. The Treat and Reduce Obesity Act, let's get that passed at the national level. And on the next slide, you'll see the bills that we have currently before the Massachusetts legislation. House Docket 3379 ensures that this full package, that full pyramid is covered for obesity treatment by Representative Santiago. House Docket 603 creates an obesity task force that would allow these medications in particular and intensive therapy to be on public health plans, to be on our mass health plan. And then, as Melinda mentioned, House Docket 2223 to address the stigma of body sizing by Representative Nguyen. Next slide. So the good news, I'll leave you with this for questions. Obesity is complex and treatable, but it takes more than eating less and exercising more. If you walk away with one thing today on World Obesity Day, is know that it is a chronic disease. It requires lifelong care, as Melinda mentioned, that she gets, and it is effectively treatable. So let's make this our next pandemic priority. Thank you very much.
There we go. Angela, Melinda, John, thank you for this great discussion and really enlightening, both of your presentations. We want to open it up to questions from the audience, so please enter your questions into the chat feature on YouTube, and we will get to as many as we can. While those continue to come in, Angela, you covered a lot of the ground that I wanted to raise, but can we talk a little bit more about therapeutics in this space? Where are we now? Are patients receptive of these? What are the access challenges that you face? I know that legislation, CMS are critical in any sort of drug development in terms of coverage, but are patients eager to get these? Are they aware of them? What's the future look like for obesity therapeutics?
I think they're much more aware of them now. I've had several people reach out to me, even just people in my personal circles, even since the New York Times article was out, right? So I think people are more aware now, and especially because some of the, our anti-obesity medications got a bad rap back in the 70s because of some, side effect profiles of some of the medications. And so there was some difficulty there, right? Some PR that we had to get a hold of, right? And I think that now with these newer medications that are coming out too, there's a lot of good safety profile. And so really, I'll point out one thing real quick that I wanted to say earlier. Greater than 80% of people take medication for diabetes, which is a disease. We know it's a disease, and we know there's lifestyle factors that can also help it, right? There are things you can do to make your diabetes better with lifestyle as well. But 80% of people take medication for that, while there's less than 5% of people take medication for obesity. So we do have to change the paradigm, right? We need a big billboard that says, it's not your character, it's your chemistry, because there is help. Right. And not that I don't want anybody to be on medication. As a doctor, I would love it if nobody had to be on any medication, but it's good that we have these things so that people can get better.
Melinda, it looks like you're trying to weigh in here, but you're also on mute.
Okay, there we go. What I was going to say is, from the patient perspective, if there's no coverage, it is a fortune for most of these medications. People can't afford it. So as much as they want to get help, as much as they believe in it and they're aware of it, when they're told, oh yes, but you can't pay, you have to pay out of pocket, it becomes reprehensible. It just becomes completely undoable. And so, to Angela's point earlier, we have to get coverage. We have to get parity of care so people can get treated.
Well, and one of the hardest parts too is that some of our medications that are generic and are more affordable for someone to buy, for example, have also sometimes side effects that don't mix well with other medications. And so it can be challenging even when people can, have access to something generic. And then there's actually laws across the country that are unfortunately biased and stigmatizing, like Melinda talked about, that actually limit people's access to these medications that are generic even. There's a law. I moved from Ohio, and part of which I did it, particularly because they have very restrictive laws around prescribing the generic medications, and you can only prescribe them for 3 months time. And so that's a challenge because the phentermine is the medication I'm talking about, and it was approved in the 70s or even before that, but it was sort of written in the way the FDA approval was that you could only take it for 3 months. So people think of, like, the world thinks of obesity as short-term treatment, right? And this is one of our struggles with access to care. It's not short-term treatment, right? It's long-term treatment. And I get that a lot from patients too. And what I say is, let's just take it one day at a time, right? Let's see if medication can help you. And then let's see if you can be free of medication, right? It's a process that's an ongoing process. It's not a like sinus infection where you just, treat it and it's done.
Yeah, and to that point, I had surgery in 2000. So, we're looking at 20 years. And to this day, I still need periodic treatment. And so, as I said way earlier, this is a disease that's lifelong. I'm in remission, lucky me, but it's not because I can do it totally on my own. It still needs treatment every now and then. So it's important that we are able to do that and get it without restrictions.
Yeah, there's absolutely no doubt about that. And, MassBio access to innovative medicines and generic medicines too is critical to what we do on a public policy advocacy basis. We want to educate and advocate on the negative impacts that insurance plan designs have on patients, whether it's out-of-pocket costs increasing year over year or prior authorization, step therapy, things like that. They have a huge impact on patients' abilities to access these medicines that really can change their life. We're getting a lot of good questions from the audience, so let me throw a few of these out here. One question is asking the potential impact COVID-19 is going to have on childhood obesity, especially when we think about kids being home for a year plus, limited activity, et cetera. Can you weigh in on your thoughts on that potential future impact?
Yeah, I think nobody has a crystal ball, right? So unfortunately, but I think COVID-19, if nothing else, has highlighted a lot of struggles in our country or in the world, right? As far as how we, how we live within, something like a pandemic. I mean, we haven't done that obviously for a long, long time. So we have to give ourselves a little bit of a break there too, because it's not like it's easy. But it is going to be a real issue. And regardless, right, it's already was an issue before. It's just we really weren't. I think if nothing else, hopefully, if something good can come out of things, right, is that we will recognize obesity as a more significant disease so that we can put some actual treatment to it. Because for the kids in particular, right, we now have a medication approved we have 2 medications actually approved last fall, like a few months ago, for children with obesity. And again, those are very hard for us to get covered. As you mentioned, because of all the prior authorizations around it as well, we have to employ a full-time person at the weight center just to do all of our paperwork to get it covered. That's a person that could go to someone to do health coaching or physical activities classes or something else, right? That would be much more impactful than filling out paperwork just so that we can get something, to treat somebody.
Yeah, absolutely. We only have a few minutes left here. And again, I want to thank you both for your time. This has been really enlightening. A few more questions that we can try to squeeze in. Melinda, I think this is a good one for you. And I'm personally curious about how I can better talk about obesity in my personal life, but somebody's asking, what are the most effective ways to help explain obesity as a disease to the broader public?
I think, I use the language part is, I think, powerful when you use the example of cancerous and you compare it to obesity, cancer, obesity, cancerous, but obese. No. So I think that's one way to do it. Use an example that's really easy to understand. And then, talk about a little bit about how obesity is linked to so many things, so many other diabetes is the easiest one to talk about. And, talk about them in the sense that they're both diseases. I think it always comes down to, we're talking about a disease. We're not talking about a description or an entity. We're talking about a disease and the whole, it's not your character, it's your chemistry, the genetics of it, the fact that our body fights against losing weight. So I think those things are helpful because people simply don't understand what's going on. And I think as you explain it, people get a little bit more aware of.
Yeah, that's really interesting, and certainly has implications around the equity conversation. I think, as you both alluded to, obesity rates in Black and Brown communities can be stigmatized, but it's certainly, based on what I've learned today, is not. That it's environmental, it's behavioral, it's part of who they are, in a way that I think a lot of people are not recognizing when they can make those judgments.
I can tell you that when I would lose weight, which was like a great achievement, I mentioned the PCP, is that all? But more than that, internally, when I would lose weight and feel like, wow, that's great. And then all of a sudden I couldn't, and I started eating again. I look at it as, 50% of people, they all can't lack willpower. That just makes no sense. It's just not possible. So something else is going on, as Angela talked about, and that I think is important for people to keep in mind, that, this whole piece of 50% of the population cannot lack willpower. It's not possible.
Makes total sense. And that's a great way to end this. Thank you again. Thank you to our sponsor, Novo Nordisk. Thank you all for attending today. We will be seeing you all at future MassBio virtual events, I hope. We have many upcoming. If you visit massbio.org and click on our events calendar, you can see some that I'm assuming will appeal to you, and I hope you see you soon. Thanks so much.
Thank you.
Thank you very much.
Thank you. Happy World Obesity Day.
Yes.
Yeah.